It's my pleasure to be sharing today this webinar from Dubai. It's 8 p.m. at Dubai time, and I'm so glad to see this large number of participants in our webinar. Before we start, the message has been sent across the Middle East and North Africa, and I'm sure that many people is interested to attend tonight the webinar by our distinguished speaker, Professor Jeffrey Cummings. This webinar tonight is sponsored by Roche and by Biogen, and we are happy that Biogen supporting the scientific content in the Middle East and updating our neurologists and health provider at the level of the region about the new advanced treatment in Alzheimer disease. Can we go to the next slide? Yes, Alzheimer disease, it's a progressive degenerative disease which started usually after the age of 65. For more than 25 years, we didn't have any new medication which is coming in the field of Alzheimer. Most of us knows that amyloid beta is one of the surrogate that we are seeing in Alzheimer disease, and mild cognitive impairment that we see as a clinician and neurologist, psychiatrist, and geriatrician, family doctor, and internist in our clinic is well known, documented with the criteria and the early stage of dementia that we see it every day and every week in our clinic is bothering us and the family regarding the future of their parents or the partners, and if they are going to be soon demented, and if this is Alzheimer or other type of dementia. A small data here mentioning that in the US alone, there's around 6.6 million of MCI or early mild Alzheimer disease. In Europe, there's around 8.2, and in UAE, we believe that there's almost more than 90,000 MCI or mild cognitive impairment patients who's going to have Alzheimer in the next few years. Next slide, please. Is unsustainable. We need around 2 or more caregiver for the patient, and in a country like UAE, family will hire a caregiver or a nurse who will stay with the patients for the next few years, and they will spend the life caring and under stress and depression because of the condition that their dad or the partners are having. We know that Alzheimer affecting the quality of care of the patient, as it's quoted here, that patient or the partner is saying that my life has shifted to revolve around my mother. And the other who's saying that absolutely the focus on the patient, but you also have to consider the caregivers. At a certain point, the disease becomes more of a burden for the caregiver than for the patient. And that what I'm saying for the caregiver and the children when they're coming with their parents in my clinic, that the patients, when they have a moderate or advanced Alzheimer, they're not aware about the problem that they have. But the caregiver, the family, the children, or the wife, they are under stress and they are suffering more than the patient. Next slide, please. Healthy academic presentation by Professor Jeffrey Cummings, who will update us about Alzheimer pathophysiology, the clinical diagnosis of mild cognitive impairment and Alzheimer disease, the management of Alzheimer patient, and the era management and follow-up of patient with Alzheimer disease. I will encourage all the audience to deliver their questions in the box of Q&A at the bottom of their Zoom. And by the end of the meeting, I will discuss with Dr. Jeffrey Cummings the questions, and I will work on categorize these questions. Next, please. So our speaker is one of the distinguished speakers at the level of the globe, Professor Jeffrey Cummings, who is a distinguished researcher and an advocate for preventing Alzheimer and fighting the brain disease. Professor Cummings is the director of Chambers Center for Transformative Neuroscience, and this center is devoted to use the tools of neuroscience and neurological drugs, which is developed to transform people's lives. Professor Jeffrey served as the founding director of the Cleveland Clinic Center for Brain Health in Las Vegas. At the same time, he has been recognized for his scientific and leadership contribution with the American Geriatric Society, and he has been awarded in 2006, and the National Alzheimer Association Ronald and Nancy Reagan Research Award in 2008. Also, he received multiple awards over the last few years. At the same time, Professor Jeffrey Cummings has published nearly more than 100 articles and more than 44 books devoted for neuroscience, Alzheimer's disease, and clinical trials. It's an honor, Prof, to be chairing this session with you. And please, you can start your presentation.
Thank you, Professor Olkran. I see we have 100 people on the line. This is fantastic. Great to see you. I have many friends in this audience, and I'm sure that I would see you there and embrace you if it wasn't for the fact that we're all in the virtual mode this evening. So I'm going to bring the slides up and look forward to presenting this material and then talking about it in the questions and answer period.
We have 2.1 thousand, we have 2,100.
Alzheimer's disease. It's so exciting to see what's going on in terms of new treatments and new biomarkers and so much advance in the science of understanding Alzheimer's disease. Here are my disclosures. I have consulted for many biopharmaceutical companies in an effort to find the best possible treatments for Alzheimer's disease. And I thank Biogen for tonight's program. They are among the companies with whom I have consulted. So again, like Professor Olkran, I'll emphasize the importance of Alzheimer's disease. I'll talk about the biology and the biomarkers, how one goes about diagnosis and treatment, and I'll talk about clinical trials and emerging therapies. So this is very like the program that you have just seen, adjusted a little bit for my lecture. So dementia in the UAE, as I looked at these figures from the dementia forecasting collaborators published in Lancet, it was striking to me that not right now in terms of dementia, so not counting MCI, but dementia, it's estimated there are about 11,000 cases in the UAE. By 2050, that will balloon to 221,000 cases. It is over a 1,000% increase. So the aging of the population in the UAE is happening at a very fast rate, so that there are going to be many more aged individuals in the population, and with that, many more individuals with Alzheimer's disease. So this is really important. We have to know how to do this, and we have to take advantage of all of the new information as it comes along. So that's what we're going to be talking about tonight. So I'll start with biology and biomarkers, or the pathophysiology of Alzheimer's disease. And I'm going to use throughout this lecture the ATN framework. And this has evolved in about the last 5 or 10 years as a way of conceptualizing the main pathologies of Alzheimer's disease. It certainly is not all of the pathologies, and we will be talking about all of the pathologies, but these are the main pathologies of Alzheimer's disease. They are amyloid, and we see this in the form of the plaque, although we'll see that there are many species of amyloid. Tau, the tau protein, it forms a neurofibrillary tangle, but again, there are many species of tau before the neurofibrillary tangle forms. And then, of course, neurodegeneration, the loss of nerve cells and atrophy, that is the cause of the cognitive decline of the patient, the loss of the neuronal framework that establishes human cognition and emotion is eroded through the loss of nerve cells. The tau and the amyloid are two conduits to the loss of nerve cells. So we'll be using ATN throughout this evening. Alzheimer's disease has been redefined in recent years. We used to think of Alzheimer's disease as a dementia. And then we thought, well, it has a beginning, so and where patients are very mildly affected, so there is MCI, mild cognitive impairment. But now, with the use of biomarkers, we know that the disease is in the brain for 15 to 20 years before the disease becomes symptomatic. So this is not a disease exclusively of older individuals. This is a disease of people in late midlife when the amyloid process begins in the brain and it builds the cascade of events that goes on to form the framework for neurodegeneration and the eventual evolution of mild cognitive impairment and dementia. So let's just look at a few of these things. There's then the long preclinical phase, 20 years before dementia. There's the mild cognitive impairment phase, 5 years prior to dementia. And then there's mild, moderate, and severe Alzheimer's dementia after the dementia itself begins. So we use the FDA staging, the Food and Drug Administration in the United States, because they are very influential in terms of advancing new therapies. You have to use their language in order to present a drug which could be approved for market. So in terms of the FDA stages, then preclinical AD are stages 1 and 2. Mild cognitive impairment is stage 3. And mild, moderate, and severe dementia are 4, 5, and 6. So the FDA has articulated this 6-stage progression of Alzheimer's disease. And of course, it's a seamless progression. All of these divisions are false because patients don't change abruptly from one stage to another. They do so seamlessly and insidiously. But we need general descriptors of the state that they're in, and that's why these states evolve. So in the preclinical stage, if we look at cognition, it's normal. And of course, in mild cognitive impairment and dementia, it's progressively more abnormal. If we look at function, activities of daily living, then in preclinical AD, it's normal. In mild cognitive impairment, it is also normal or nearly normal, maybe a little erosion. And then the definition of dementia includes cognitive and functional impairment. So when functional impairment is clear, then the patient meets criteria for dementia and progresses through mild, moderate, and severe stages. Amyloid is present throughout all these stages. It is the first thing that we can detect in the progression of Alzheimer's disease. We can do that either with CSF studies or we can do it with amyloid PET. So it becomes abnormal, again, 20 years before dementia. And of course, it remains abnormal throughout. Tau may be abnormal early, but is more likely to become abnormal in mild cognitive impairment and in dementia. And neurodegeneration, so see again, we're using ATN, neurodegeneration, usually absent in preclinical AD, usually absent in mild cognitive impairment, though of course it's just beginning, that's why symptoms are there, and then more flagrantly involved as we go through mild, moderate, and severe dementia. So this gives you a sense of the progression of Alzheimer's disease, this long preclinical tail that comes before symptoms begin, how cognition and function are impaired as the stages go on, and how the ATN framework frames the biology that is progressing over the course of the illness. Now, here's another way of imagining this or envisioning this. This is work that I did with Colin Masters. You see the amyloid plaque in the upper left-hand corner. You see the neurofibrillary tangle in the lower left-hand corner. These are drawings from very early manuscripts where they realized these two pathologies. So in the upper framework, we see stage A, B, and C of the Thal stages. And you see with the progressive coloration from green to red that there's a progressively larger involvement of the cortex by the amyloidogenic process as the disease goes on. Similarly, early in the illness, there's stage 1 and 2 of the tau phases or the Bruck stages. And 1 and 2 is present in most normal elderly individuals. This is a tauopathy which is present, but it is mostly asymptomatic in older individuals. In stage 3 and 4, as the amyloid begins to get worse, there is then a concomitant worsening of the spread of tau in the cortex. And then that goes on to stages 5 and 6. So you see what's happening in the brain as our patients progress. Starting with the amyloid, that amyloid, the deposit occurs fairly early and then is stable. On the other hand, tau is progressive and more tightly correlated with a cognitive decline. Amyloid is a central component of Alzheimer's disease. Of course, there's a lot of controversy about the amyloid hypothesis, but there was no controversy about the importance of amyloid as a central defining component of Alzheimer's disease. Pathologically, one cannot diagnose Alzheimer's disease without amyloid present, and we now use amyloid measures to confirm the diagnosis of Alzheimer's disease. On the left, I'm just showing you this progression of different phases or different species of Alzheimer's disease. So it begins with the amyloid precursor protein, APP. This is a very large protein. It is then cleaved by gamma secretase and beta secretase. And that frees up then the monomer that you see there. That's a single molecule of 42 amino acid length amyloid. That 42 amino acid shape tends to aggregate. So it forms dimers and trimers and eventually oligomers, protofibrils, and then fibrils. The greatest toxicity, at least in the laboratory, is with the oligomers and with the protofibrils. And then the fibrils, although they seem to be very important as we see the action of the monoclonal antibodies, they do appear in the laboratory to be less toxic. So we're still trying to understand the relationship between the oligomer and the amyloid plaque. Now, let me point out a problem that we have in the field. When we do a spinal tap, and now when we do plasma measures, we're measuring the monomer. When we do an amyloid PET, we're measuring the plaque. And we are blind to everything between the monomer and the plaque, including the species that we think are most toxic. So this is a great unmet need in the field and something that keeps us from progressing, because if we cannot measure our target, we also cannot tell how effectively we are impacting our target. So that's one of the things that many scientists are working on at this time. So we have tau spread in the brain, and that is occurring in the context of amyloid. So on the left-hand side, I'm showing you a primary age-related tauopathy. This is what I've mentioned. Most older people have tau in restricted areas at the base of the brain. Then in the middle figure, in the blue, you see that amyloid begins to accumulate. When that happens, the tau is greatly exacerbated. We've called it, Keith Johnson has called it, the catastrophe that is going on in the brain. Because all of a sudden, as the amyloid appears, then the tau begins to propagate very fast. And then in the figure on the right, you see the widespread propagation of the tau. In the lower panel on the right, I'm showing you cell-to-cell tau spread. This is such a fascinating phenomenon. It's just like prions, where the tau protein, the monomers, the dimers, the early species, because these are organized just the same way amyloid is, are passed from cell to cell. And as they enter the next cell, they form the neurofibrillary tangle and kill that cell. But then the dimers and the trimers have already gone on to the next cell that they will kill. So this is the progression, is a prion-like propagation of the tau molecules. And it is that extracellular component which has been the target of many therapies for tau monoclonal antibody development. We'll be talking about those later in the lecture. Here's a map of the dynamic change of the biomarkers of Alzheimer's disease. Let's start on the right with the amyloid figure. So you see, again, many years, 15 years before MCI and 20 years before dementia, the amyloid is deposited in the brain, and it's fairly much at a plateau level by the time MCI begins. It does not continue to accumulate progressively across the entire illness. It accumulates early in the illness and then plateaus, as you see here. Then you see synaptic dysfunction occurring in yellow. You see the tau and tau-mediated neuronal injury in green. Now that's starting to be present in MCI and very present in late MCI and early dementia. You see the brain structure changes, which you can see with MRI, which of course is the most familiar tool to all of us. And then you see that's followed by cognitive and eventually functional decline. If we look at the bottom of the figure, we see A present throughout the illness. Then we see T beginning before MCI, but much later than A. We see neurodegeneration, and it can occur early or it can occur late, which is why that dotted line is there. So you see the ATN framework is evolving below the evolving clinical symptoms of Alzheimer's disease. And there is more variability than we had expected. So some patients have AT and N fairly early. Some patients have AT and N fairly late. So we're still trying to understand how ATN relate to each other in this biological framework. Here is some really exciting observations. I just am so amazed that in such a short period of time, we have come very close now to having blood-based diagnosis of Alzheimer's disease. So let me take you through the biomarkers of ATN. So again, at the top of this table, you see A and T and N, amyloid, tau, and neurodegeneration. The pathology of A is the A beta species and the A beta plaques, just as we've seen. The pathology of tau are the tau species and neurofibrillary tangles. And the pathology of neurodegeneration is neuronal death and synaptic loss. In the CSF, we can measure A beta 42 to 40 ratio, and that goes down as the amyloid is sequestered in the brain. So it goes up in the brain and down in the spinal fluid and plasma, 42:40 ratio. In the spinal fluid, we can also measure phospho-tau, an important precursor of the neurofibrillary tangle. And we have two epitopes that are measurable right now, p-tau 181 and p-tau 217, and you'll be able to get these in the laboratory, I think, within 2 years. For neurodegeneration, our best CSF measure is neurofilament light, NFL, and it progresses in all neurodegenerative diseases. It is non-specific as a measure of neurodegeneration, whereas p-tau and A-beta 42:40 are both more specific to Alzheimer's disease. Now look at the blood measures. This is so fantastic that we also have A-beta 42:40. In the United States, we actually have 2 approved vendors for the A-beta 42:40 measure. So we can order that just like any other laboratory test. I think that's coming to many countries. We have the ability to measure p-tau 181 and 217 in the blood. That is not commercially available in the US, but certainly companies are progressing towards making that available very soon. And we can measure NFL in the blood as well. Again, it's not commercially available, but it's coming soon. In terms of imaging, for A, we have amyloid PET. That measures, again, the plaque or fibrillar amyloid. We have tau PET, which reflects the neurofibrillary tangle, not the phospho-tau, although it is hyperphosphorylated tau in the neurofibrillary tangle. And for neurodegeneration, we have MRI, which measures atrophy. You're very familiar with this. And FDG PET, which measures metabolism, which is declining in quite a specific way in the course of Alzheimer's disease. So you just see how much progress has been made in biomarkers and how important they have become in terms of identifying Alzheimer's disease in life and allowing us to choose therapies and follow therapies. Now, I just wanted to show you these beautiful imaging techniques. So on the left, I'm showing you the amyloid scan. This, of course, is for A. You see a normal scan on the left and the positive Alzheimer's scan on the right, on the first panel. You do see that increased signal in the normal brain because it is the ligand is going through the white matter quite slowly. So of course it's emitting radiation, which is detected by the detectors of the computer and shows up as a high signal. So one of the areas that we really need to improve are better amyloid images that have less of a white matter confound in terms of our reading. But you see there's quite little overlap here between the normal and the abnormal. Now, in the middle panel, I'm showing you the tau PET scan. So on the left, again, you see a little bit of tau there in the medial temporal regions, but very little. And then on the right in that middle panel, you see where the catastrophe has occurred. And now you see a lot of neurofibrillary tangles out on the edges of the medial temporal and lateral temporal cortex, up in the frontal cortex. So you see that the tau has really spread around and easily detectable by tau PET. And then on the far right panel, I'm showing you the MRI. You're very familiar with this. You see the normal scan on the left of that panel and the abnormal scan on the right. You can see the ventricular enlargement. You can see the general cortical atrophy, and you can see the hippocampus here that is greatly atrophic with a subsequent enlargement of the ventricles that are around the hippocampal region. So these are 3 just great types of neuroimaging. The most specific of these, of course, is amyloid scanning, tau scanning, very useful in Alzheimer's disease. I'd like to make the point that this tau scan that we have now is very specific for the tau of Alzheimer's disease. And if you use it to scan a patient with progressive supranuclear palsy, it'll probably be normal because it doesn't attach to that kind of tau. Now, I want to make one final point here before we leave the biomarker section. And that is, the more biomarkers we have, the more we can understand our patients and offer prognosis. So looking at the graph, you see the gray area, the gray line is A negative, T negative. It's declining slowly with age from 45 to 75. We're measuring cognition on something called the preclinical Alzheimer Cognitive Composite, or PAC. You see very little happens in the patient who's A negative and T negative. Now, if tau begins to accumulate early on, I've said really that's a normal phenomenon. So A negative, T positive, again, very little happening. There is a little worse performance, but very little is happening in terms of progression. Looks pretty much like a normal individual. If we go to A positive and T negative, again, not very much happening there. Pretty much just like the normal individual. We know that the amyloid can be present in the brain for a long time without making many symptoms. But now, look at A positive, T positive. You see that orange line. You see the very rapid progression from age 50 to age 75. That patient is going to be symptomatic. That patient's going to get MCI. That patient's going to progress from MCI to Alzheimer's disease, dementia, and we can tell it from the biomarkers. So you see that the combination of A beta 42 to 40 and say p-tau 181 or p-tau 217 is going to be such a powerful tool for you to use with your patients, because you can literally tell which ones are declining and which ones are not going to decline. It's a very powerful set of insights that we've never had in our patients before. So I'd like to leave the pathology and the biomarkers. We will be coming back to biomarkers when I talk about drug development, because they've become central to drug development, and go on to clinical diagnosis of early Alzheimer's disease. Why am I emphasizing early Alzheimer's disease? It's because most of the recent work has been in patients who have MCI and mild AD dementia, and we call that early Alzheimer's disease. So it's not early onset. We're not talking about young patients. This patient can be 85 years old and have early AD because they are in that stage of MCI to mild AD dementia. That is early Alzheimer's disease as we define it now. 40% of all clinical trials going on in the world today are conducted in this population. This is where we're going to have new therapies. This is where all the monoclonal work is going on right now. So very important that we understand this phase of the illness. So how could we approach this? Well, again, I've given you the diagnosis of early Alzheimer's, MCI due to AD, and mild AD dementia. Now, what we've learned is that accurate diagnosis is very challenging. 55% of 2,000 patients in a recent study, 18,000 patients in a recent study, of those 55% of the MCI patients did not have AD. So it's about half and half. About half of the patients who come to you with MCI have early AD. And about half of the patients who come to you with MCI do not. They're either in the early stage of another illness, they have vascular disease, they're depressed, they have temporary impairment due to medication or life circumstances. Something else has happened to them. Some of those patients go back to normal, some stay MCI, some progress to another dementia. Half of them progress to Alzheimer's disease. And you can't really tell which half without a biomarker. So you need a biomarker. Again, 20 to 40% of mild AD dementia do not have AD. So this is amazing. And this is something that I think has humbled all of us neurologists. We all thought we could make a great diagnosis, and I'm sure we're usually right, but 20% of the time we're wrong. And we think the patient has Alzheimer's disease, and they don't, because there was no amyloid in the brain. So again, before we would give anyone an amyloid-specific therapy, we would need to know that they have amyloid in the brain. Very important. So in this way of thinking about it, then AD, Alzheimer's disease, equals a confirmation of the diagnosis by an amyloid biomarker. Those that are available right now and would be considered diagnostic are the 42 to 40 A beta measure in the spinal fluid and amyloid PET. We are getting increased confidence in the A beta measure in the plasma. And I think when we have maybe a combination of plasma and other biomarkers, plasma A beta and other biomarkers, we'll be confident enough to make a diagnosis with the clinical phenotype and the biomarker. But be aware that many patients, a surprising number, who look like they have Alzheimer's disease do not. So what do they look like? Well, the most common clinical phenotype is episodic memory deficit. So they have forgotten what they did yesterday. And when you give them the 3 words on the mini-mental or the 5 words on the MOCA, they do not remember them because that is an episodic recent memory defect. And that's characteristic of the invasion of the medial temporal hippocampal region by the pathology of Alzheimer's disease. That's where recent memory is mediated. That's the effect of that early effect on the medial temporal regions. If you test language carefully, you will find mild impairments of naming with low frequency objects. So that's one of the things that I test for. And then they usually have mild visual spatial deficits. Sometimes you can detect this with clock drawing. Sometimes you need some more complicated drawings for them to copy. In the MCI stage, there's no or limited functional impairment. It's an insidious onset and gradual progression, so it's very slow. And it's common that a family history of dementia is present. In our clinical trials, for example, where we have confirmed the diagnosis of Alzheimer's disease with amyloid, about 60 to 70% have the ApoE4 genotype. And that means they got it from one of their parents, and that means it's pretty likely that one of their parents had Alzheimer's disease. Now, not everybody with an ApoE4 gets dementia, but many of them do. So when you see the family history of dementia, it gives you more confidence. Yes, this is likely to be Alzheimer's disease because we see the risk running in the family. What are some other risk factors? There's a lot of them, and we've learned a lot about brain health. And I find this one of the most fascinating areas where growth is occurring. So what are the risk factors? Family history of dementia and E4 genotype. I've just mentioned that. Age, of course. The older the person is, the more likely they have to get Alzheimer's disease. Female sex. They're more likely to have Alzheimer's disease. And I know we have a lot of women watching this evening. It's very important to know that this disease falls disproportionately on women. And we have to understand that better. It may be related to hormonal features, but we don't know that for sure. Low educational levels make Alzheimer more likely. Low levels of physical exercise are more common in Alzheimer patients. Poor sleep, poor diet and nutrition, stress and depression, obesity, diabetes, smoking, and hypercholesterolemia are all risk factors. And you see then how many of them are modifiable and can become a brain health recommendation that you give to your patients and their families. So you can say, let's exercise more. Let's try to sleep better. Let's look at your diet. Let's control your weight. Let's make sure your diabetes is under control. Please stop smoking and let's lower your cholesterol. There are already 7 brain health interventions that we can do with our patients and their families to lower the risk of Alzheimer's disease and slow the progression of Alzheimer's disease. So these are very, very important. But of course, the more risk factors one has in a symptomatic patient, the more likely they are to have Alzheimer's disease. So it's very important to think about this as you're taking the history for the likelihood of Alzheimer's disease. Now, biomarkers, we've been talking a lot about this. Of course, readily available is the MRI, and many patients get an MRI or a CT scan, and we have N information from that, neurodegeneration. Less widely available in the world are FDG PET, again, an N measure, CSF A beta 42 to 40, an A measure, an ApoE genotyping, and ApoE is related to amyloid in the sense that the E4 positive individuals are more likely to have amyloid accumulation in the brain. Available in some countries is amyloid PET. We have 3 versions of amyloid PET approved in the US, and tau PET, we have 1 version approved in the US. None of these are funded by our Medicare, they're very expensive, and so they're rarely used outside of the research setting. We also have available in the US plasma 42 to 40 measures, and we're really starting to get an experience with that will help us understand its role in the disease. And as I mentioned before, coming soon are going to be plasma p-tau 217 and maybe plasma p-tau 181. So when we have the plasma measures, then it becomes realistic to have a biomarker reinforced diagnosis of Alzheimer's disease. You may not have access to a PET scan. I think that's going to be common all across the world, but we all will have access to blood tests. And I think that will greatly improve our diagnosis. It will improve our detection, and it will improve our ability to monitor the therapies that are coming or are already approved. So as I think about moving towards a precision diagnosis in Alzheimer's disease, I think about the presentation, which would be a gradual onset, and memory loss being most predominant. Of course, there are variants that are unusual, but memory loss will catch most of the patients. You take the history. The patient is sitting next to you. You're taking the history from the spouse or the oldest child. You take the family history. We emphasize that. You look at the risk factors. I've emphasized that. You listen to the history of memory decline and determine whether function is has a major degree of impairment. Next, you do the mental status exam. Certainly, you want to include something with word list recall. I like the MoCA, for example, and I use the MoCA in my clinic. You might want to do clock drawing or some other visual spatial test. And I like verbal fluency. A person should be able to name 12 animals in 1 minute in English. I don't know what this would be like in Arabic, but it would be similar, that when you explore a category, but the person has to search their memory stores to come up with that name. That's often impaired pretty early. So 12 animals in a minute is what one expects. And I think it's probably close to that in Arabic, but you can look. The neurological and cardiovascular exam, of course, the neurological exam should be normal, right? If it's not, it's some other type of dementia or at least a mixed dementia. The cardiovascular exam is either normal or it's not exclusively the cause of the dementia syndrome. And then biomarkers to the degree that they are possible for you, MRI, FDG, CSF, and plasma are all in various states of availability. So you see, we're moving towards a more precise diagnosis of Alzheimer's disease. It's important because we have to have that as a part of precision therapy of Alzheimer's disease. So this is how I conceive of that. It's still aspirational right now, but it's coming. So let's move on then to the management of Alzheimer's disease. This is, again, an area of great progression. Now, I want to start with the widely available, commonly used standard of care medications for Alzheimer's disease. So most available and most widely used in the world is donepezil, that's known as Aricept in the United States. I know it has other names in other countries. It's a cholinesterase inhibitor. It is approved for mild, moderate, and severe AD dementia. It is not approved for MCI. There's a new patch form of donepezil available in the United States called Adlarity. Again, it's approved for mild, moderate, and severe AD dementia. Rivastigmine is the drug that I would usually use if the patient got diarrhea or some other GI side effect on donepezil. It comes as a patch. It comes in 3 doses. It's approved for mild, moderate, and severe Alzheimer's disease, and it's approved for Parkinson's disease dementia. It is the only approved drug for Parkinson's disease dementia, and it's the only approved drug approved for more than one dementia syndrome. Galantamine is also available. This is Razidine. It comes in the short-acting or the XR form. The XR form is most widely used. It's approved for mild and moderate AD dementia. Also available is memantine or Namenda in the United States. This is an NMDR receptor antagonist. It is approved for moderate and severe AD dementia. So the more stages 5 and 6 rather than stages, for example, 3 and 4. And then in the US, we have a fixed combination of donepezil and memantine. This is called Namzaric. And it is available for moderate and severe Alzheimer's disease patients who are stabilized on memantine and donepezil, and you want to change them to 1 pill per day. So this is the repertoire of drugs that are available to you as the standard of care. The most common side effects of the cholinesterase inhibitors are gastrointestinal abnormalities. And the most common misperception that I hear is that patients progress on these drugs because they cease to work. There's no evidence of that. Yes, patients progress, but in every study, whether it was a patient with mild, moderate, or severe dementia, when they were treated, they function at a higher level than the patient in the placebo group. So they're declining in parallel, so they are declining, but they are always functioning at a higher level than the patient who is not on treatment and comprised of the placebo group in the trial. So these are important drugs. I use them in every patient. A combination of a cholinesterase inhibitor and memantine was my standard of care as the patient progressed through the illness. I would also use the higher doses of the cholinesterase inhibitors if patients could tolerate them. There are more side effects with higher doses. Now, I also want to mention the use of drugs for the control of behavioral disturbances in Alzheimer's disease. This is such an important area. This is often why your patients come to you, right? The families are bringing the patient in because some behavioral disturbance has occurred at home and they want help. Now, I'll begin by emphasizing that none of these drugs are approved, at least in the US. In Europe and in Canada, risperidone is approved for BPSD, the behavioral and psychological symptoms of Alzheimer's disease. In the US, none of these drugs have ever been approved, but I will give you a little update of what's happening. So let's begin with agitation. And you may be surprised that at the top of my list is brexpiprazole or Rexulti. This is an antipsychotic. It's at the top of my list because 2 years ago, we published 2 positive trials of Alzheimer's disease, agitation. And 2 weeks ago, they announced that they had a positive 3rd study of agitation in Alzheimer's disease, and that will almost guarantee they're going to the FDA and with approval. I see no reason that they wouldn't be approved. FDA approval is difficult, of course, but they have they have not only 2 trials that are required, they have 3 trials, all of which show statistically significant outcomes. So I think brexpiprazole is on track to become the first drug to be approved for the treatment of agitation in Alzheimer's disease. Also widely used are risperidone and quetiapine for agitation. There's very little evidence that quetiapine works, but it is popular. And one advantage of it, of course, is its very wide dosing range. For psychosis, again, I would start with pimavanserin. Why is that? The FDA just decided not to approve it for Alzheimer's disease. But the major reason was that the sample size was too small, and you could still see the benefit of the pimavanserin, and it is approved for psychosis in Parkinson's disease. So it's approved for another neurodegenerative disease. All of that adds up to me to become a candidate for use in psychosis of Alzheimer's disease. It's very specific. It's a 5-HT2A inverse agonist. Also used in psychosis, of course, are risperidone and quetiapine. Depression, you would usually use a drug that is well known in the elderly, such as citalopram or duloxetine. There's no new activity there. In terms of apathy, which is pretty common in Alzheimer's disease, it's actually the most common neuropsychiatric symptom. There has been a recent phase 3 trial of Ritalin, which was positive. So we have now better evidence that Ritalin does reduce apathy in Alzheimer's disease. And then an area that is really interesting to me is the use of the dual orexin antagonist for Alzheimer's disease. There are 2 that are approved and have been studied in Alzheimer's disease and have had positive clinical trials, and they are suvorexant and lemborexant. The great thing about these drugs, and I think that we're going to understand them better over time, is that they improve nighttime sleep and they improve daytime wakefulness, because the dual orexin mechanism is a circadian mechanism. So what you're doing is restoring the circadian rhythm rather than putting a patient to sleep with a hypnotic. So I like these drugs. I use them more. I think they're good alternatives. I don't know what their payment status is in the UAE. This should give you some idea of the drugs that you have at your disposal to use. And then I want you to know how things are evolving with the new brexpiprazole trial, the new methylphenidate trial, and the new emphasis on the dual orexin antagonist in Alzheimer's disease. Now we have one disease-modifying treatment approved for Alzheimer's disease. This is aducanumab or Aduhelm. It is approved for early Alzheimer's disease. Again, we know what that is, MCI and mild dementia due to AD. To initiate a patient on aducanumab, the patient needs to be amyloid positive by either PET or CSF. They need to be at low risk for ARIA complications, so they should have no more than 4 microhemorrhages on a baseline MRI. They cannot be on an anticoagulant. Again, that increases the risk of microhemorrhage with treatment with a monoclonal antibody. The ApoE genotype should be determined because the risk of ARIA, as I'll show you in a moment, is related to the ApoE4 genotype. The patient has to be able to comply with monthly infusions and MRI monitoring. It is a rigorous demand on the patient and the caregiver, but of course, it has the promise of slowing progression. And the patient has to understand that the intent of therapy is to slow progression and not to improve the symptoms. That's an important distinguishing factor from the other medications we've been talking about. They do not slow the progression, but they often do improve the symptoms. So let's look a little bit at the aducanumab data. It's an anti-amyloid monoclonal antibody. The FDA defined it, noted that it affected a defining pathophysiological feature of Alzheimer's disease. That is, it is disease modifying. There was marked amyloid plaque lowering, and I'll just call your attention to the figure on the right. So the red area on the scan, this is an amyloid scan, is the amyloid. The 2 top figures, the patient was on placebo for 12 months, and you see there's absolutely no change in the amyloid burden. On the very bottom set of figures, you see the patient who was on 10 milligrams per kilogram. You see a lot of amyloid in the brain at the baseline, and you see that it actually has been eliminated to undetectable levels by the end of 12 months of exposure. This is a dramatic, unthinkable reduction in amyloid plaque burden in the brain. It's amazing. In some of the trials, 80% of the patients become amyloid negative in the course of the trial. There were data supportive of a relationship between plaque lowering and slowing of clinical decline. Of course, this was very controversial. I'll tell you why I think it's true. And it was approved using the accelerated approval regulatory pathway. This is commonly used in the United States, so it has not been used in Alzheimer's disease before, based on a biomarker that was considered reasonably likely to predict clinical benefit. And that biomarker was amyloid lowering on amyloid PET imaging. So again, you see the importance of biomarkers. They're actually the basis for the approval of some drugs in the United States now. So let's look a little bit at the data. There was the EMERGE trial and the ENGAGE trial. The EMERGE trial was positive. The ENGAGE trial was negative. So on the EMERGE trial, the CDR sum of boxes, which was the primary outcome, demonstrated a statistically significant slowing of 22%. In patients who received 10 milligrams per kilogram for 14 months, which was the intended therapy, they had a 30% slowing. Secondary outcomes, 40% slowing on the ADL measure, 27% slowing on the cognitive measure, and 18% slowing on the mini-mental. In the ENGAGE trial, which was negative on the primary analysis, but when one looked at the patients who had 10 milligrams per kilogram for 14 months, as we did in the EMERGE trial, they had the same 30% slowing. So the exposure response is the same in these two trials. It's just that fewer patients in the ENGAGE trial had 10 milligrams per kilogram for 14 months, and more patients in the EMERGE trial had 10 milligrams per kilogram for 14 months. And that's the difference between a positive and a negative trial. In addition to plaque reduction, there were very interesting downstream effects. In the spinal fluid, there were significant reductions in total tau measures and in phospho-tau measures. And then on the left, this is great. Look at the tau PET scan imaging used in the trial. And I've drawn a circle here around the medial temporal regions that had a high burden of neurofibrillary tangles at the beginning of the study. So you see in the circle on the left, there's a high burden and intense signal. After the treatment, you see that signal is very much reduced. And if you look at each pair of tau PET scans, you see exactly that same pattern with less neurofibrillary tangle ligand signal on the right-hand figure after treatment compared to the left-hand figure before treatment. So not only is there an effect on amyloid, but you see you're interrupting the network of interacting pathologies of ATM when you are able to remove one element of that network. So I'm very interested in the way the biomarkers are reflecting the wide range of effects that occur when we give these drugs. Now, of course, this is a drug that is not simple to use. I led the group that came up with the aducanumab appropriate use recommendations. These were independent of Biogen, by the way. This was a group of scientists and clinicians who thought that clinicians needed more use than the prescribing instructions provided. So here you see the dosing. There are monthly infusions. There's increasing dose. You go from 1 milligram for 2 months to 3 milligrams for 2 months to 6 milligrams for 2 months, and then to 10 milligrams per kilogram for the rest of the patient's life. There's MRI at baseline, rest of the patient's life. I shouldn't say that. When they exit the stage of mild AD dementia, at that point, it is negotiable with the family whether they think the patient is benefiting or not. We don't have evidence beyond the mild AD dementia stage. So the patient may stop the therapy after the end of the mild AD dementia stage. Of course, what we're hoping to do is to prolong the period that the patient is in MCI and mild AD dementia and shorten or abbreviate that period where patients are in severe disease. The patients get an MRI at baseline, and then they get an MRI in the 5th, 7th, 9th, and 12th doses just before. Just after the 5th, 7th, 9th, and 12th doses. And they get an MRI if any symptoms of ARIA occur. The most common symptom of ARIA is headache. The second most common symptom of ARIA is confusion. ARIA stands for amyloid-related imaging abnormalities. So here's our thinking about how to manage ARIA. So this is the major side effect. Altogether, it occurred in 40% of patients. Now, it is very related to the genotype. So an E4 non-carrier had ARIA 20% of the time. A person who is a heterozygote with one E4 copy during the course of the trial had ARIA 36% of the time. A patient who was a homozygote and had two copies of the E4 gene had ARIA 66% of the time. So that's why we're saying patients should be genotyped, because when you have that discussion with the patient, there might be a big difference in terms of their decision whether their risk of ARIA is 66% versus 20%. So it's very important that we get the genotype. Most ARIA occurs during the titration period, much more uncommon later. It occurs with higher doses, so you're likely to see it later in titration. 74% are asymptomatic. So the patient doesn't have any idea that something happened. You detect it on those routine MRIs. 1.4% in emerge and engage were serious. So it's important that even though this is a low percentage, it is still important that we be aware of it, monitor it, and know how to manage it. So the monitoring and management plan are important. So if you look at our flow chart on the right, you have a baseline MRI, and again, it must have 4 or fewer microhemorrhages at baseline. Then the MRI is conducted regularly or with any symptoms suggesting of ARIA. If ARIA is detected, either from a regular scan or from a symptom-based scan, if the patient had symptoms, then treatment is stopped. MRI is repeated monthly, and aducanumab can be restarted if the patient has resolution of ARIA-E or stabilization of ARIA-H, the hemorrhagic form of ARIA. In addition, if the patient had moderate or severe ARIA, with or without symptoms, again, they have the same management I just described. If the patient is asymptomatic, that is, the ARIA is detected by routine MRI, and the ARIA is mild, then dosing can continue, although the patient should be imaged every month to determine whether there's any risk or evidence of worsening. We also produced in our update recently the stopping rules. That is, any macrohemorrhage leads to stopping. More than one area of superficial siderosis leads to stopping. More than 10 microhemorrhages occurring since treatment began leads to stopping. More than 2 episodes of ARIA, because those patients are likely to go on to progress to more severe ARIA. Or severe symptoms of ARIA. Patient has severe headache, severe confusion, has a seizure. Those are the things that would make you stop the patient's treatment with aducanumab. Again, you see that's going to be less than 25% of the patients because 75% are asymptomatic. So this is a guide to how to use aducanumab in the clinic. We have to be able to rise to the demands of these drugs in order to offer our patients therapies, and more of these drugs are coming. Now, why does ARIA occur? What's happening with ARIA? Well, amyloid is deposited in the blood vessel in Alzheimer's disease, as well as in the plaque. So as the amyloid is drawn out of the brain, removed from the brain by the monoclonal antibodies, it is also removed from the vessel wall. That creates a temporary interruption of the vascular integrity, and there can be the escape of fluid or blood into the brain parenchyma, causing ARIA. So it's ARIA-E, ARIA effusion type if it's fluid, and ARIA-H, ARIA hemorrhage type if it's blood. The vessels recover over that first year of therapy, and ARIA is uncommon after the first year of therapy. So you see here an illustration of how ARIA is occurring because the amyloid is being pulled out of the vessel wall, creating the opportunity for the leakage of vascular contents into the brain. Now, the last part of this lecture is devoted to clinical trials and emerging therapies. I want you to know what's coming, and some of this is coming soon. We're going to have the readout of several trials this year, 2022. We're going to know so much more at the end of this year than we do now that it's going to be truly amazing. 2 more monoclonals will read out, and some of the small molecules will read out. So I want to just make sure that we're all on the same page in terms of how drugs are developed. Of course, they begin in the laboratory with non-clinical discovery and animal testing. You look for the biological and safety effects. In phase 1, these are usually normal, healthy volunteers. And first you have a single ascending dose, so they just get 1 dose, and then the next group gets the higher dose, and the next groups get the higher dose until you discover the upper dose. After that, you do a multiple ascending dose study. So patients are exposed for 28 days, then another group is exposed for another 28 days at a higher dose, then another group at the next 28 days with a higher dose, and again, until you discover the upper allowable dose. Once you know the dose, then you take the drug into Alzheimer's disease. And you look for proof of concept. Is there evidence that the drug is working? And more, this is based on biomarkers. These studies are larger, 400 to 800 patients. If that looks good, then you'd go on to phase 3, which are confirmatory trials, must show clinical benefit now, or in rare cases, you could have accelerated approval if the clinical benefit was evident, but not completely proven. It then goes on to FDA review, which is a comprehensive review for safety and efficacy, and could receive market approval. Now, throughout this process, biomarkers are playing an important role. In the animals, we use biomarkers to measure the effects of treatment. In phase 1, normal volunteers, we use liver functions. You know, we've forgotten about these as biomarkers, but they are. And we use EKG, which is a biomarker of cardiac function. In phase 2, we use biomarkers for diagnosis, for determining target engagement. Is the drug doing what we want it to do? We look at dose response if we can, and we look at safety, and that may also be a biomarker. Similarly, in phase 3, we use biomarkers for diagnosis, supportive to provide evidence supportive of disease modification and for safety. In the FDA review, the pharmacology section will describe the biomarkers, and in some cases, biomarkers will be used for the management of the drug. We've also thought about the rights of drug development. There's a 99% failure rate in drug development. Part of that is because the drugs didn't work. Part of that was because the development program was not well designed. What are the elements of a well-designed development program? They are defining the right target, that it has to be druggable, it's supported by genetics, and there's a biomarker. It has to be the right drug, that is, it has drug-like properties. We know its metabolism. The maximum tolerated dose is known, and a dose response is known. It has to be the right biomarker. We've emphasized that. Participant selection, target engagement, and outcomes. They have to be the right participants. Now you see we have preclinical patients, we have prodromal patients, or those early Alzheimer patients, and we have severe dementia patients, moderate and severe. Which population is right for this drug? That's an important decision for the development program. And then, was it the right trial? Was it well-powered, well-conducted? The data are trustworthy. With these 5 rights, we can look at whether a development program is well structured and whether it is likely to either be definitively negative, which is important, or of course, definitively positive. Here are all the drugs in the current pipeline for Alzheimer's disease. And some of you know that I publish an annual review of the pipeline with this figure updated annually. To read the figure, the central circle are all the drugs in phase 3. So they're in the final stage of testing. The middle circle are all the drugs in phase 2. So that's proof of concept. And in the outer circle, they're in phase 1. They just came out of the laboratory. They're going into humans, usually healthy volunteers for the first time. Each of these icons has a different color, or you see groups of different colors. And that is related to a classification of disease pathology developed by the NIH here in the United States. So red is for amyloid, yellow you see is inflammation, orange is neurogenesis, and so on. Tau is dark blue. So you see that all of the drugs in phase 3, at the time we did this particular biopsy of the pipeline, all the drugs in phase 3 that are biologics are aimed at amyloid. So the upper part of the pie in green are all disease-modifying biologics, mostly monoclonal antibodies. The yellow part of the pie on the left, the orange part, are cognitive enhancers. That is, they make patients better, like donepezil and memantine. The blue slice of the pie on the left are the neuropsychiatric symptom drugs. So we talked about those, like brexpiprazole. And the purple slice of the pie on the right are disease-modifying small molecules. So these would usually be given by mouth. You see that all together, there are 143 agents in 172 trials. In phase 3, there are 31 agents. 21 of these are disease-modifying therapies. In phase 2, there are 82 agents. 71 of these are disease-modifying therapies. In phase 1, there are 30 agents. So altogether, 83% of the drugs in the pipeline are disease-modifying agents. So you see, we have to begin conceptualizing the future of our practices as giving disease-modifying agents. Yes, we're going to continue to give the symptomatic drugs, but we're also going to be giving disease-modifying agents. We have to conceptualize of our practices in terms of disease modification. We have to conceptualize our discussions with our patients and their caregivers in terms of disease modification. This is what's coming. It's 80+% of the pipeline. Cognitive enhancers are about 10% of the pipeline. Neuropsychiatric symptom drugs are about 7% of the pipeline. Interestingly enough, 37% of the pipeline are drugs approved for some other reason. That is diabetes or hypertension or hypercholesterolemia or Parkinson's disease or multiple sclerosis or some other agent. So that's what the pipeline looks like right now. If we look at this classification of processes, starting at the bottom, you see amyloid, tau, inflammation, neuroprotection, metabolism, proteostasis, vascular, oxidative stress, and so on. And so you can see the population of the drugs devoted to the different targets in the pipeline. So you see, there are quite a few amyloid drugs, but there are actually more drugs aimed at inflammation, synaptic toxicity, almost as many drugs as are aimed at amyloid. So these are very popular targets in the pipeline. We're going to see drugs that address new types of pathology as we go forward. So here on the right is a comprehensive picture of the pathophysiology of Alzheimer's disease. You see, of course, that there's oxidative stress and mitochondrial function. There's defective homeostasis. Proteins are handled abnormally in proteostasis. There are epigenetic changes. There's amyloid, there's tau, there are vascular changes, there's inflammation. Very complex illness. So a lot of the times I hear, well, Jeff, we're investing too much in the amyloid drugs. But you see, actually 77% of the pipeline is non-amyloid and non-tau. So amyloid is 14% of the pipeline, Tau is 9% of the pipeline. 77% of the drugs are devoted to other targets in Alzheimer's disease. So I think that we are exploring a wide repertoire of targets, and we're looking at what these targets, how these targets might respond. And we're thinking about what are the combinations of therapies that could keep our patients functioning at the highest level for the longest period of time. That's what we need. That's what we want for ourselves as we age. So that's what we're looking for with these multiple targets. Now, I want to call attention to some of these processes because they're just so interesting. So here I'm showing you a picture of inflammation on the left. You can see the major actor in inflammation is the activated microglial cell at the top. So we all have resting microglial cells in the brain. These can be activated by A-beta oligomers, by degenerating neurons, or from inflammatory cells entering from the peripheral circulation. The activated microglia then can itself engulf proteins, but it also releases destructive chemokines and cytokines. So this is an extremely complicated process. On the right, I'm showing you all the drugs in the pipeline that are currently devoted to inflammation as their primary target. Here's the amazing thing, which you can see is that almost none of them are addressing the same target in the inflammatory network. So you see, starting at the top, we have a TREM2 antibody, TREM2 being a critical part of the inflammation cascade. You see that we have regulatory T cell drugs. You have cytokine antagonists. You have leukotriene antagonists. You have MAPK inhibitors. So the point is here, there are many targets within inflammation that are being targeted. And we're going to learn a lot from this over the coming years. The same is true of synaptic toxicity. So I'm showing you the synapse at the top. It is impaired in terms of its integrity by A-beta oligomers and by degenerating neurons. Now, for me, the important parts about this is that the synapse is the basis for the circuitry in the brain. And it is brain circuits that are the basis of human cognition and human emotion. And therefore, the impact on the synapse will be translated into the impact on the circuit, and therefore human cognition and emotion. And again, I'm showing you on the right all of the drugs that are aimed at synaptic toxicity. And again, you see almost none of them are focusing on the same target. So we have sigma-1 agonist and M2 antagonist. We have mGluR5 modulators. We have gingipane inhibitors. We have sigma-2 antagonists. We have SVA2A modulators. What's the point? The point is we're exploring multiple disease-related targets in each of these categories of disease in Alzheimer's disease. It speaks to the complexity of the disease. It speaks to the wide range of our attack on the disease. Here are some anti-diabetic agents. I find this fascinating. So, of course, diabetes is a risk factor for Alzheimer's disease. Obesity is a risk factor for Alzheimer's disease. Both of them cause peripheral inflammation, and peripheral inflammation enters the brain and causes central inflammation. So that's a primary concern of these diseases. When that happens, we have increased A-beta, increased neurofibrillary tangles, and increased insulin resistance in the brain, leading to neurodegeneration. In phase 3, we have a trial of metformin, and we have 2 very large trials of semaglutide, a GLP-1 agonist. So we're going to, again, learn a lot about this. In phase 2, we have a SGLT2 inhibitor, a PPAR agonist, and insulin. So a lot of work in phase 2 as well. So we're going to learn about, can we affect the metabolism of the cell in the brain in Alzheimer's disease? And can we manipulate peripheral inflammation to the benefit of the patient? Vascular factors, I want to call attention to this because it is the one area where we are already seeing combination therapies. So you see there's a phase 3 trial of losartan, amlodipine, and atorvastatin. You see there's a phase 2 trial of telmisartan and perindopril. You see that there are already combination therapies in the vascular area of Alzheimer's disease therapeutic development. I'm looking forward to seeing these trials come to fruition. Now, I want to call attention to tau-directed therapeutics. We've talked about ATN. I've emphasized amyloid and tau and neurodegeneration, both in diagnosis and now in terms of therapy. So here you have the tau biology. You have the tau going into the microtubule, then coming apart in dimers, trimers, and aggregated forms into the oligomer, into the protofibril, and into the neurofibrillary tangle, just as we saw for the creation of the species and the plaque for Alzheimer's disease. Then you see those fragments of tau can be passed from cell to cell. I talked about this before, and that forms the basis for the Bruch staging 1 and 2, 3 and 4, and 5 and 6. We have quite a few drugs in the tau pipeline. We have aggregation inhibitors. We have monoclonal antibodies. We have one vaccine. We have an antisense oligonucleotide. This is fascinating. You give it intrathecally into the CSF. We have an O-glycanase inhibitor and a drug aimed at microtubular depolymerization. So a lot of drugs aimed at different targets in the tau biology. Amyloid, of course, remains a popular target for therapies for Alzheimer's disease. So you see on the left, you see the large amyloid precursor protein, and then freeing it up by gamma secretase and beta secretase to form the A-beta monomer, which forms the oligomer and the plaques. There's also peripheral A-beta monomers. So we have some small molecules aimed at disease pathways. For example, if the alpha secretase pathway is stimulated, then A-beta is not generated. Reduced APP transcription is the target of Posifan. Decreased pyroglutamate A-beta, which is at the heart of the plaque, is the target of PQ912. There are drugs looking at amyloid transporters, amyloid aggregation. So again, we have small molecules that could be taken by mouth that are addressing A-beta pathology. The area of greatest interest are the anti-amyloid monoclonal antibodies. So aducanumab is directed at the plaque and oligomeric A-beta. I've emphasized the importance of the oligomers. This is already approved. Donanemab is in phase 3. It is oriented towards the A-beta plaque and pyroglutamate A-beta. Lecanemab is in phase 3. It is addressing the A-beta plaque and protofibrillar A-beta. Gantenerumab addresses A-beta plaques and oligomeric A-beta and is also in phase 3. Solanezumab is in phase 3. It has failed trials in symptomatic Alzheimer's disease, but we'll have a readout soon in a prevention trial of people who were asymptomatic at the beginning of the trial. Now, lecanemab and gantenerumab will read out at the end of this year. So that's what I mean. We're going to know so much more about these drugs at the end of the year than we do right now. It's just going to be a really exciting time of growth in our information and understanding. There are also novel directions in the AD pipeline that I want to call your attention to. There are amyloid and tau vaccines, the antisense oligonucleotide I mentioned. Epigenetic interventions are being developed, as are stem cells. I've talked very little about stem cells, but they are in early phases. They're tricky to use. They're tricky to test, but they're emerging. The same in phase 1, we see epigenetic interventions and stem cells. Now, finally, I want to talk about the role of biomarkers in trials. So the way you're eventually going to know how to use biomarkers in your clinical practice is by understanding how the biomarkers performed in the clinical trial. So here I'm showing you the basic biology of Alzheimer's disease with the neuron, the plaques, the vessels, the astrocytes. And I'm showing you the corresponding biomarkers. I will not go through each of these. But on the right, I show you that in terms of biomarkers, we have biomarkers for A, T, and N. I've already shown you those. We also have biomarkers for inflammation, synaptic dysfunction, vascular function, blood-brain barrier integrity, oxidative stress, and microbiome products. So we have an increasingly wide repertoire of biomarkers that we can use in trials and eventually will be translated into practice. The FDA has a very specific way of naming biomarkers. And when a company uses a biomarker in a trial, they have to say exactly what the context of use of the biomarker is. That is the way they prove that that biomarker is reliable and valid and can be used to garner information in the trial. So the 7 categories of biomarkers that the FDA recognizes are risk biomarkers. ApoE would be an example. Diagnosis biomarkers like amyloid PET. Monitoring biomarkers like our plasma measures. Pharmacodynamic biomarkers, again, like amyloid or tau PET. Predictive biomarkers, which predict either an effect or an adverse event. And you see that ApoE4 predicts adverse events. It identifies a population at increased risk. Prognostic biomarkers are those that give you an idea of the course of the patient. So there, you have to distinguish between predictive, which have to do with therapy, and prognostic, which have to do with the disease, and safety biomarkers like MRI. And I'll just give you one example. This is from the Trailblazer trial of donanemab. The patients were chosen on the basis of tau PET. I'm showing you in the upper panel 2 examples. They had to have some tau PET, but not had to have some tau on PET, but not too much tau on PET. So it's an example of choosing just the right population based on the biomarker. On the lower left, you see that tau PET also functioned as a pharmacodynamic biomarker with less accumulation or removal of tau during the course of the donanemab trial. In the upper right, I'm showing you p-tau 217 derived from the plasma. Look at this. As the A beta goes down and as the tau is affected, you see that the p-tau 217 reduces in a very regular, statistically significant way. That's why we could use p-tau 217, we think, in monitoring the monoclonal antibodies when they become more widely available. And of course, amyloid was the primary concern, was donanemab producing amyloid reduction. And again, you see in the lower right, amyloid PET as a pharmacodynamic marker of reduced function. So you see the wide use of biomarkers in clinical trials. I'm going to finish just by making some observations about clinical trials that we noted. One, I've already pointed out that 40% of all trials are in this early Alzheimer's disease phase. 6% are prevention trials, 26% are in mild to moderate disease, and 8% are in moderate to severe disease. If we look at the contribution of patients to our trials, and we add up the number of weeks that they participate and the tremendous number of participants that it takes for all of our current trials, you see that they're contributing 3,800,000 weeks of participation in trials for all of the trials currently ongoing. It's a remarkable contribution by our patients. Clinical trials are global, and I would love to see more trials in the Arabic countries and in the UAE. You see that the phase 1 trials are about equally done in North America and outside of North America. Phase 2 trials, there's a little preference for performing them in North America only, though 30% are conducted only outside of North America. And interestingly, at phase 3, 40% include both North American and non-North American sites. They're truly global trials. We're engaged in a global enterprise, a global scientific enterprise. We should take pride in that because we're all contributing to solving the problems that our patients have. Who pays for trials? You see that 68% of the agents that go to phase 3 are paid for by the biopharma industry. On the other hand, in phase 2, there's about an equal percent paid by federal sources and academic sources and the biopharmaceutical industry. So phase 2 is much more widely sponsored by different entities, and phase 3 then becomes largely a biopharma enterprise. It's important. That's who you'll be negotiating with for a phase 3 trial. Drug development in Alzheimer's disease arises from a complex ecosystem. In our country, we have the National Institutes of Health that provide funding. We have academic medical centers, biotech and pharma companies. We have capital, venture capital that's invested in drug development. Advocacy groups like the Alzheimer's Association, CROs, sites where trials are performed. We would love to see more sites in the UAE. The regulatory authorities like the FDA, and they of course cooperate across the world. There are payers such as insurance companies, and there's extensive training that's required. So this is a vast ecology of interactions. So I'd like to summarize my talk. Thank you for staying with me. We have still a lot of people online. Alzheimer's disease prevalence is rising at a remarkable rate in the UAE. This is going to be a demand on your practices. The ATN Alzheimer pathology is reflected in the ATN biomarkers, just a remarkable growth in how we understand the disease and how we can access it peripherally. Precision medicine is coming to Alzheimer's disease and will be facilitated greatly by the blood-based biomarkers so that we don't have to depend on expensive testing such as PET or CSF. Drug development for Alzheimer's has multiple targets. We're really learning a lot about how to impact the biology of Alzheimer's disease. Aducanumab is approved and available. Other monoclonal antibodies are progressing. We're going to learn a lot this year about monoclonals. Aducanumab is efficacious and defined management strategies that allow you to use it safely. So here's all my gang that helps me develop all of this information and follow it in the clinical trial pipeline. I'm eternally grateful for them and grateful to them and to the funding that I have received. And I thank you for your attention.
One of the things that I'm so happy about that this video is recorded and it will be on our free YouTube channel if that's fine with you, and we'll be more than honored to review this and to share it with our residents and our doctors in the Middle East. Second thing is definitely UAE and Dubai will be more than happy to take part in these clinical trials in phase 3 and to be able to contribute with our patient in the region. We have many people who's looking to be part of this trial. Second thing is we have plenty of Q&A, and I have many questions came through the Q&A bar and also through WhatsApp and message by friends. So we will have less than 30 minutes. So let us to start with the first questions. This from Dr. Amal. Despite the horrible prevalence of Alzheimer all over the world, there's no enough centers to deal with these number of patients and their family. Why is that?
That is just a great question, Amal. And we have it in the United States as well. There are not enough medical students who choose to go into neurology or geriatric psychiatry, where they would be dealing with Alzheimer's disease patients and other dementias. Somehow it just must not be an attractive area of specialization, even though the science is so great right now. I mean, you just couldn't want more to be able to work with your patients, but it's just not happening. And it's not happening all around the world. And I don't have an answer for that. We need somehow to attract many more students, or maybe it's a different kind of workforce development. We're thinking about advanced practice nurses as being able to do much more than we have used them before. And I think that's an opportunity as well. So we have to rethink how we're going to deliver care to this literal tsunami of patients that are coming.
Okay, thank you. Question number 2, is there any evidence regarding the improving neuroplasticity with the hyperbaric oxygen therapy?
Yeah, really interesting question. And I know that there's a lot of interest in this. There are not a lot of data, and it has not been presented to the FDA. I see pretty convincing data that patients may improve while they're in the chamber. But of course, the improved oxygenation stops when they leave the chamber, and it seems like the effect is not long-lasting. So I think we have to understand it better. We don't have good data, but it may be that it's too transient of an effect, and that's why it hasn't really caught on.
And that's what we noticed because it became so popular in the Middle East here with the hyperchamber oxygen that patients will improve with they will get between 3 cycles to 4 cycles per week. And patients' cognitive function, their attention will improve, but after discontinue the hyperbaric by almost 4 to 6 weeks, they will go back to their baseline.
Yeah, interesting. See, this is a great example. You're teaching me, I'm teaching you. That's why we need this kind of cooperation.
Questions from Dr. Muhammad regarding why we are late with the biomarker serum 1 compared to the clinical trials, which is reaching phase 3.
Let's see, I missed that question. Read it one more time.
Regarding the serum biomarkers, why we are late in getting different type of serum biomarkers compared to the clinical trials which reached phase 3?
Yes, good question. I think it's because we're kind of out of phase in developing the biomarkers. With the biomarker, the drug started earlier. And of course, a trial that's coming to fruition this year started 5 years ago. So all of the planning had to be before that. And those biomarkers just weren't available at the time. The incredible time frame of clinical trials it's very slow. So I think it was just that the biomarkers were not available when the trials were planned. If you look at Trailblazer, they're using serum biomarkers for screening and a telephone test. So you get a telephone test, a serum biomarker, then if you're a candidate, you would go in for more advanced screening. I think that's a great use of serum biomarkers in our current level of understanding. I'm hopeful we're eventually going to be able to use them for diagnosis. But I think the reason that they're not in the trials now more is because they weren't planned. I will tell you one thing, we're going back and looking at a lot of the biomarkers. I've been part of the lecanemab trial, for example, and we're just working on a paper right now of the biomarkers, which were not planned measures, but we had all the blood. So we just went back and measured all the biomarkers, both from the baseline and with the outcome of the trial. So we have a very good repertoire of biomarkers in that trial that we're doing retrospectively rather than prospectively.
Interesting. And also during the presentation, the last part when you showed that how many different mechanisms is there that the drugs can work on to inhibit the inflammatory process or amyloid or the tau. All these mean that we will have different biomarkers for all different part of the chain.
Yeah, I wish we did. That would really be great if we had a comprehensive look at the biology. But if you think of ATN, for example, that's 3 elements of a very complicated process. They are probably the 3 central elements. So that's very important. But we need to know, if you treat amyloid, do you decrease inflammation in the brain? Because inflammation may be very important. Or if you treat tau, do you have a greater effect on inflammation? And would that be a good outcome? So we need more biomarkers to understand maybe not the target, but the downstream effect of the target. So I think we still have way too few biomarkers, but they're hard to develop. They're hard to be confident of them until you have a lot of data. And so we need more work on them.
The good news here at the level of UAE that we have 2 centers that they are doing the CSF amyloid for the before starting the AntiAmyloid MAP or the monoclonal antibodies here in UAE. So the patients who's candidate for this through Biogen, they can do the CSF amyloid screening to confirm their diagnosis before starting the treatment, which is something happy to have here in UAE and in Dubai. There's a question by Dr. Farhan Khan. How to differentiate between the MCI and senile dementia or memory losing because of the aging?
Yes, really good question. And one of the ways, of course, is the biomarkers. That's one of the chief reasons for thinking about biomarkers, because the amyloid biomarkers are specific to Alzheimer's disease. But we know that there are normal changes in cognition with aging, particularly slowing of cognition. Getting to that name when you want it is something that everybody experiences, and you experience it more as you age. So there are changes in normal aging, and that differentiation is particularly difficult in the very early stages of the illness. So that's a challenge. The biomarkers are helpful. I've emphasized the importance of episodic memory and testing it and looking at the profile of Alzheimer's. A family history can be helpful to you. So that's one way of doing it. The concept of senile dementia has largely been remodeled into Alzheimer's disease and other dementias. Senile dementia is almost like the word dementia, a very general term. And then if they're older and they have dementia, is it Alzheimer's? Is it frontotemporal? Is it vascular? Those are the questions we're asking. So the concept of senile dementia has itself been remodeled with greater specificity.
Thank you again, Prof. There's questions regarding from Dr. Khalid. If you stop the medication due to the ERA, do you return to the same dose again?
Yes, very good question. So if somebody develops ARIA, do you go back to the same dose after you have interrupted the therapy? And the answer is yes. So let's say that they get ARIA at 6 milligrams per kilogram, which is pretty common. You would hold it. If the ARIA disappears, the ARIA-E disappears, then you go back and start at 6 milligrams again. Now, I think if a patient was off for a long time, 6 months, you might want to retitrate. But that's not the case. Usually these disappear within 8 weeks, so you're confident to go back and give them the 6 milligrams again. So yes, you go back to the same dose, and that is something that comes up, and it should come up, right? Because if 40% of patients have ARIA, then we should be re-examining them in 40% of the cases.
I had a question when you were doing your presentation regarding how effective are the treatment in removing the amyloid from the brain, where in both trials, almost 80% of the patient had more than 80% of amyloid has been removed from their brain. Do we need to reach that low in the concentration of the amyloid, as we know that it's taking long time to accumulate, more than 20 years before they start to be symptomatic? Is there a time that we can give the bolus of 2 to 3 months of the medication, then to give a gap of 6 months to prevent the ARIA, then to come back and evaluate these patients regarding their amyloid? My question is, do we need to reach that level of 80% cleaning?
These are just great questions because they're exactly the questions that the field is trying to work on right now. For donanemab, they have taken a position that you can probably interrupt therapy. And for donanemab, their target is exclusively the plaque. It's the pyroglutamate A beta. So for them, when the plaque is gone, the reason for giving the drug is gone. So they're taking a position that you could have an induction phase and then maybe a maintenance phase. With the other drugs like aducanumab, they target both the plaque and the oligomer. And we think that oligomer is important and we can't see it, right? We can only see the plaque.
I agree.
So right now, we don't know whether those drugs would benefit the patient to have continuous therapy and keep the oligomer down because we know that the plaque is down, but we don't know what's happening to the oligomer. So that's a biology that still has to be worked out. And it's why an oligomer biomarker is so important. Okay. We can't seem to get it. The reason is, by the way, this in itself is interesting. I mentioned how the dimer becomes a trimer and then it becomes a oligomer. That process is going back and forth all of the time, so that the monomers are first they're oligomers, then they're dimers, then they're trimers, then they're tetramers, so on. So a measure of something that is that dynamic is very difficult to develop. And so far, nobody has solved it, though I think people will. I think, mankind is clever. And I believe that some way, somewhere, someone will figure out how to do this.
Interesting. Thank you again. There's a question from Dr. Kosia. Any ongoing trial on role of sphenopalatine ganglionic stimulation in Alzheimer's disease?
That's a really great question. Again, I'm not aware of a trial, but I see the end of the sentence is to support the theory of chronic cerebral hypotension to increase collateral circulation. And I think that second part of the sentence is really important because sphenopalatine ganglionic stimulation is one way to approach that. But there are a lot of other vascular approaches, and there are several of them. I showed you several of them in the pipeline. And so I'm watching those with great interest because, one, we know that amyloid is in the blood vessel, so there is that vascular disease. We know that mixed dementia is extremely common with lots of white matter pathology when we look at our patients' MRIs. So a combination of an Alzheimer's drug and a vascular drug might really make sense. And maybe that's what we'll learn with sphenopalatine ganglionic stimulation. But I would keep the question sort of wider than that. How can we look at the relationship between vascular disease and Alzheimer's disease?
Interesting. There's a very important question from Dr. Ibrahim Amin. Many thanks, Prof. Would you recommend population screening for Alzheimer's disease? At which age? And how to screen the people for Alzheimer? We are having a cure or a treatment which can prevent a progression of disease. We have a screening for different type of cancer. We have a screening for cardiovascular disease, screenning for diabetes mellitus, screening. How about Alzheimer? Are we going toward a screening tool, which is blood test, MRI, other things which can confirm that and prevent progression of disease?
Yeah, I love this question because what it addresses is how can we remodel our healthcare systems to take better care of older individuals? And I think screening is going to be very critical. And we're getting so close with the blood test. Now, an older man goes in, they get a PSA, determine whether they might be at risk for prostate cancer, and then you follow through with that. Why couldn't we do that with Alzheimer's disease? I would say right now, we don't have the answer to what is the best biomarker or combination of biomarkers. Is it going to be a low A beta 42 and a high p-tau 217, or is a high p-tau 217 enough? We just don't know the answer to these questions, and we want it to be as inexpensive as possible and as widely used as possible. Those would be our goals, and they might just have a high false positive rate. That would be okay as long as they had a low false negative rate. So we didn't miss anybody, but when we refer somebody on for more examination, maybe there's really nothing there. It was just a false positive. That's okay. So we're working out what is the positive predictive value, what's the negative predictive value, What is the sensitivity? How scalable are the tests so that we can get them all around the world? These are the questions that have to be answered. But I love this idea. I think it's so important that we think about how to conceptually remodel our healthcare systems to become much more involved in prevention, and the use of the blood test will be an important part of that.
Interesting. Thank you again. A question about how do you see the urgency to treat MCI?
I'm sorry, see the
urgency.
Urgency, yes. Oh,
treat
yes.
MCI. If I have a patient with MCI, who I believe is a mild cognitive impairment, and maybe there's going in the direction of Alzheimer, is it an urgent to treat these patients? Is it an urgent to confirm our diagnosis?
So I think yes. I think we're moving into that area of Alzheimer care where we want specificity. Let's take an MCI patient who doesn't have AD, but they kind of look like AD, and you tell them they have AD, and then they get better. That is not a good place to be. So what I want in my patients is to be able to do a test that confirms the diagnosis enough, maybe not amyloid PET, maybe I would accept the blood test at this point, the low A beta 42 to 40 in a patient with MCI, have the discussion with them. What do you want? You do have the signature of a patient who is going to progress. Do you want to consider aducanumab as a therapy? And if so, then it becomes important to further confirm it and start the patient on therapy. But even if the patient says no, or if they have MCI that's not AD, that patient needs help, right? You have to talk with the patient. Are they depressed? Do they have vascular disease? How are they thinking about it? What is their family response to them? Do they have a will? These kinds of things that need to be thought through as we all approach the end of life. So I think it really is urgent to try to figure out what the patient has, and then construct alternatives for them.
Thank you. A question, it seems, from a clinical practitioner who's saying, very simple question. If one has a positive first-degree relatives with a history of Alzheimer's disease, and she's a female, what are the top 3 modification risk factors that you will advise and focus on?
Yeah, I'm so enthusiastic about this brain health idea. Christine Yaffe's work shows that we could reduce the overall world prevalence of Alzheimer's disease by about 30% if the whole world practiced, brain healthy lifestyles. Now we're not going to get very close to that, but if we could reduce it by 10%, that would be amazing. So it would have to be tailored to the patient. If she smokes, then stopping smoking is really important. If her diabetes is not well controlled, if she had diabetes, that would be very important. If you think overall about a generally healthy person, it is exercise more, even if it's just walking and, getting out and making sure that your heart rate gets up. That's very important. A good diet that avoids too much red meat and is more vegetable, fruit, and fish and poultry based. And I would say, and having been in a lot of Arab countries, the family is so important. And I think that network of family connections and helping each other and the interconnectedness of the family is really important. And I would just make sure that network is really working.
There's a question from Dr. Al-Kuwaiti. Can we start mild to moderate dementia patient on the new treatment? Would there be any benefit?
Yeah. Again, I just love these questions because this is a question I have in my mind, right? We have migrated towards treating earlier and early patients in terms of, and even including the prevention trials. But I think we need to look at those mild AD dementia patients, mild to moderate AD dementia patients. But they were not included in the trial, and therefore we don't know whether they would respond. So until a trial is done, or at least some open label tests or something is done, we can't answer that question. But here's an interesting observation from my point of view. When the populations are divided into those that had MCI and those that had mild AD dementia, they did equally well, despite the fact that they probably had different levels of pathology. So right now, we don't have indication that earlier is necessarily better. Of course, we want patients at the highest level. That's why we treat them earlier. But if they're already at a lower level, can we offer them something? We don't have that answer, but we need that answer.
Okay. Questions, the last two questions I can say. Is ARIA something that should make us not prescribing this new medication? Should we be worried about that? As you mentioned that most of the patients is asymptomatic, but is it something that we need to be worried about?
Yes. Again, this is a question that we've really been very involved with here in the US, because the medical community here is somewhat polarized about this. And some people say there's too much risk of harm, and others say not. My position is that we have to be vigilant about it. But there's a lot of evidence that with the proper management, and I gave you some ideas about that in my little flow chart, it's very rare for a patient to get into serious trouble. That if we look at the patient who died, for example, in the US, and it was attributed to ARIA, that patient had a long-standing inflammatory disorder. She got very ill and the drug was continued. And it was only, she was later transferred to a very intensive care setting and she died there. The ARIA was probably a part of that, but she was probably the wrong patient for it. And it probably should have been stopped much sooner than it was. So I think the key here is, just like every other drug that you use, you need to understand the drug well, and you need to know how to monitor it. And with those caveats, I think that this is a safe drug.
And I will advise the people to go back to the presentation, which will be on the YouTube channel, and look to the algorithm that the prof presented regarding the management of ARIA and the medication when to start and how to change the normal algorithm of treating patients. There's a question by Dr. Abu Zahira. He's saying, thank you, Prof, for the presentation. I would like to ask if there's non-pharmacological treatment of Alzheimer's disease, and how about intranasal insulin, which he read about?
Yes, both good questions. There are non-pharmacologic treatments, and they're the ones that I've called lifestyle interventions, and they are pretty effective. They're the magnitude of the effect is similar to a cholinesterase inhibitor, for example. And the best study is one that was done in Finland, 2-year study with patients at risk for mild cognitive impairment. It included exercise, diet, and control of cardiovascular risk factors. And there was a statistically significant treatment placebo difference. It wasn't a drug treatment, it was a lifestyle treatment. So I like that trial a lot. And that's being reproduced now on a worldwide basis. So we're going to have a lot more data on that. So there are definitely non-pharmacologic treatments, and there are many of them actually. For example, music therapy has been pretty good for agitation. So there are other sort of specific circumstances where non-pharmacologic interventions have been of value. In terms of the SNF, the insulin trial, that was called SNF, the background was pretty strong. The basic science was pretty strong, but the trial was negative. And that read out, I don't know, about a year ago. At this point, we don't have evidence to continue with insulin. I mentioned that we're testing semaglutide, and which is a GLP-1 agonist. And the interesting thing about that is not only is it an anti-diabetic agent, but it's also an anti-inflammatory agent. So you're getting multiple effects from one pathway in the brain. So although the sniff was negative, I think that other diabetic agents are still of great interest.
The last questions from Dr. Mohammed Al-Madani. Can biomarkers, which is coming in the pipeline now, be used as a screening tool in non-symptomatic patients in the future, especially in those patients with a high risk or positive family history?
Yes.
Is that what we are looking in the next
we touched on this before, that I'm very enthusiastic about getting biomarkers that can be used on a routine basis when older people, maybe we'd say, I don't know, what, 60 and above or 65 and above would start getting biomarkers, or maybe it even should be earlier, given how earlier amyloid accumulates in the brain. We have to figure out exactly how it would be done. But yes, I think screening of normal, healthy individuals in anticipation of the high rate of amyloidosis which occurs is worthwhile, but we need to know how early to start and exactly which combination. Is it A beta and tau, or is it A beta and neurofilament light? These are the questions that have to be answered scientifically, but they're coming, and they're coming remarkably rapidly. That's the great thing about the state that we're in right now, is every day there's some new discovery that seems exciting to me.
So unfortunate, this lecture's presentation need to be ended. I'm so honored today to be chairing this session with Prof. Jeffrey Cummings. Sir, I'm the president of Alzheimer's Neurology Society, and you are more than welcome to be invited to visit Dubai this year or next year to update us about the dementia, Alzheimer, and what's coming in the pipeline. It was a pleasure to have you with us today to go through basic science of Alzheimer's disease, dementia, risk factor, diagnosis criteria of early Alzheimer, MCI, then to go through the clinical practice that we are having now and the new evidence coming and the future clinical trials from phase 1, 2, and 3, and what's coming soon before the end of the year. So happy to have you with us tonight. Thanks, Prof, for being with us.
Thank you, Professor. It was my pleasure. And thanks to all the people. I see we had a great group online. I really appreciate it. And I appreciate the invitation. And I'm coming to the UAE as soon as I get a chance.
Thank you again. I would like to thank Biogen for organizing this webinar, education webinar, and thanks for MCO and Shada for being with us tonight. Thank you again and wish you the best. Assalamu alaikum.